Welcome to the Orthopedic Indications channel, where we discuss medical education for medical sales consultants and reps. We just did a journal club a couple weeks ago that was really interesting. It basically presented a case, a scenario. So in this particular setting, we presented a young athlete, late teens, early 20s, collegiate football player who sustained a midfoot injury with a primary ligamentous Lisfranc injury. And we presented this in such a way where we put the residents into teams, and their assignment was to go through the literature and come up with a paper that best represented the appropriate treatment for this particular patient. And not only like the treatment, but including the workup, the classification, how you want to fix it, what the recovery looks like, what are you telling the athlete and the family in terms of the recovery. We were divided into teams. We had the team present their paper, and then there was 5 teams, so they each presented a paper, and then they had to defend the paper that they had chosen. So the assignment was the first team, the first come, first serve, basically. So once we send out the emails, the chiefs had to go through, read the literature, figure out which paper they were going to use, and then send it to us. And there could not be duplicates. So at the end of the selection process, we had 5 different papers that were presented. So I'm going to highlight those papers because it was a really interesting discussion. So the way that we did it is the medical students presented the paper, and they had like 4 or 5 minutes to present it, and then everybody kind of listened in. The faculty that were present then voted on which paper they liked the best. And then what we did is we had the chiefs come back on the back end, and they had to basically provide a rebuttal of why they felt their paper was better than the other ones. So it required them to read critically not only their paper, but every other paper so that they could come up with a logical argument at the end of the day. Then we went through and voted on which paper we felt was best presented, which one we felt best represented the case at hand, and basically, see who won. But the prize was the ultimate prize, which is bragging rights. I'm going to talk about the papers that they presented because I think it's really interesting as you think about this. So number 1, no particular order, and I'll tell you who won at the end of this. Chris Coetzee's paper, 2006, primary fusion versus ORIF for primary ligamentous injuries. Obviously this one has to be included because some of the discussion is what's your primary strategy for fixing these, and do they need a fusion or do they not? And, in this paper, that's like 20 and 21 in each group. And we saw that like 92% satisfaction with the primary arthrodesis, 65 with the ORIF, more people going back for hardware. But, that doesn't include like routine hardware removal as you may usually do with an ORIF. The AOFAS scores were a lot higher as well. And so you could argue maybe that's not a great judge. But I think people came away from that level 1 study saying like, hey, do we need to rethink how we do these? Is a primary fusion maybe a better option for some of these cases? So that's paper number 1. Again, no particular order. Second paper, out of Pennsylvania, McHale's case-controlled of 28 NFL athletes. And this paper was from 2016, I believe out of the American Journal of Sports Medicine. And it was interesting because it was a case-controlled study, level 3 evidence. And what they did is they looked up data on NFL players who sustained a Lisfranc injury, and that was over a 10-year period of time. And then they compared them based off their power ratings in terms of how they did after they came back from their injury. And so they found about 90% of these players that they returned to their sport. Their time to return to sport was about 11 months, and all but 2 out of the 28, I believe, had returned to sport. So most of them are able to get back to sport. The stats were a little bit decreased for that group that had the injury, obviously, but that wasn't statistically different. I think one of the problems we have with some of this publicly available data is sometimes we don't know what to trust it. We don't know if one Lisfranc was equal to the other, if they were actually reported as Lisfrancs and maybe they weren't, degree and severity of the injury as well. You have all the challenges of when do you actually return to sport? When do you count it? Like what's your time 0? Because you could be in season and you miss part of it and trying to get back towards the end of the season. Although most of these are season-ending injuries, or you could have it happen at the end of the year and you don't play again until the next season, which is obviously going to extend the time. So it's a little hard to trust the data in some of these studies in terms of like knowing if this is actually accurate. But that was study number 2. Study number 3 from 2015, Scott Ellis's paper from HSS. This was out of the FAI. They looked at 38 patients who were deemed to be young and active, and I think there was an age like less than 50, and looking at some of the activity levels in these patients. Most of them, like 66%, two-thirds, said their difficulty of activity was about the same as prior to the injury. So that's pretty decent. 34% reported increased difficulty. Most of them were able to get back to their activities. A little hard to know like how intense is the activity, a breakdown of the different activities that were done. Probably the most intense activity that most people did was running. That was 17 of the patients. And then less than 10 were really doing things like basketball, football. I think lacrosse was in there as well. So some of the more like cutting, pivoting kind of things in that paper. But that would be paper number 3. Okay, paper number 4 was out of the military, and this is by Joe Bellamy and the group out of the Navy. Kevin Kuhn was on this paper. It's a level 3 comparative cohort study, so comparing it between a couple different groups in the military. So primary fusion versus ORIF. This was over a 5-year period of time. This paper is out of AOFAS, and I think it was in 2017. So what is interesting is their actually primary fusion group was able to get to full duty at an average 4.5 months compared to the ORIF group at 6.7 months. And they had a little bit better runtime when compared to their preoperative average compared to the ORIF group. And then the foot and ankle ability measure was about the same between the group. And then obviously you're going to have more hardware removal. So it makes you think a little bit, at least, about the role of this, and particularly if there's a bad chondral injury in some of these. And finally, this paper was the winning paper, Dr. Porter's paper out of Indianapolis. This is a paper that was published in FAI in 2019. This had, I think, 82 patients, so probably the largest of the cohorts. It's just a case series, so it's a level 4, so that's maybe a downside, but you can certainly read through this paper and understand the extensive experience that Dr. Porter has managing a lot of these injuries. He did a great job of breaking these down into 3 different pattern types, and it kind of helps the clinician recognize the different patterns and strategies for fixing a lot of these. And he went through the protocol for rehab and the approach that he takes with a lot of these athletes. So case series, a lot of surgeon experience, doesn't have a comparative cohort to say primary fusion. So that would be a little bit hard argument to make based off this paper. So this is the winning paper based off the medical student presentation, the chief resident defense and rebuttal, and the application to the case that we presented at the time. So kind of a fun journal club, kind of fun to go through and actually rehash these articles after, and from my perspective, so that I can actually sit down, use the information that's at hand, interpret it, and then figure out how I want to apply that to the patients that we see in our clinic. So great way to really engage the residents. They did a phenomenal job. And it's kind of a fun idea to use, and I'm hoping we get to do it again soon. Take care. Cheers.